they would have no respiratory depression whatsoever. So there's testing, there's animal testing that suggests strongly that there's no respiratory depression. And what's more, there are also pharmaceutical products that are not in common use, but nonetheless have been patented, they have IP protection, and they are FDA approved, which are biased ligands. So the big pharma recognizes that biased ligands are a potential way to go too, in terms of creating new molecules. So that's really what I wanted to talk about. That's where, for me, the rubber hits the road with kratom use, and I would look forward, when all were done, to take any questions related to it. So thank you very much for your time, and again, for the opportunity to address you.
We will conclude this scientific panel with Dr. Jack Henningfield, but please also remember that while she couldn't be here today, Dr. Nora Volkow, the director of the National Institute on Drug Abuse, has submitted written testimony. Dr. Henningfield.
Thank you. Can you folks hear me okay? Great. It's an honor and a pleasure to be here. Every time I have an opportunity to participate in an event in the Capitol, I take a walk around the Capitol when I'm done and just marvel at the fact that we can actually do this and have input and interact with people like Representative Bergman and Pocan, who help make this happen.
I will give you $100 for every question you answer correctly in this 28-degree ice bath.
Dr. Volkow isn't here, but you've heard a lot of the research that is being done because Congress funded NIDA to do this research. It comes together. It's great to be the last one, because part of my mantra is, how do we get FDA in the game? You heard from Drs. McCurdy and Smith the diversity of products in the marketplace. And, well, what do you do about that? FDA is the best organization in the world, hands down, to figure out what should the standards be. What should the labeling be? Over-labeling is as bad as under-labeling. Should products say caution causes seizures? I'll bet FDA would conclude no. You don't put a label on just because something might do something. That's dangerous. Anyway, that being said, next, let me see, hopefully this will work. If it doesn't, I'm going to ask you folks to do it. Disclosures, I consult in this area. I've been working in addiction research since 1971 in neuropharmacology, and working in drug regulation since that was part of my job in 1980 at NIDA, working with FDA and DEA. And I still work with FDA and DEA, and I respect what they do. And we don't always agree, but they're all trying to do what we're trying to do, get it right. Just in a couple of things that I'm going to mention, a little bit of the history that you've already heard. A lot of what, and a lot of the history that FDA ignored. When people ask me, how did FDA get it wrong? My answer is, well, they came to the table late, about 2011, 12, and they didn't consult with NIDA researchers, and they didn't consult with Southeast Asian researchers who had been studying it for decades. There's a lot of promising developments, and that includes findings now. The science base is incredible. And you just heard from some of the pioneers in science in this area in the United States, and they stand on other pioneers. Dr. Smith, it's amazing. She's become a pioneer in just a few years. She's a NOVA pioneer. And congressional encouragement of FDA is happening. And that's encouraging, because a lot of times FDA needs encouragement from the United States Congress to say, why don't you do this? Give us cover, et cetera. Let me go back with just a couple of things about some of the history. Well, guess what? In 1972, Smith, Kline, and French allowed their scientists to publish the results of their exploration of mitragynine as a new pain drug. And you already heard a lot of what they found back in late 60s, 1970s. I think they were allowed to publish it because for whatever reason, maybe patent reasons, the company decided not to go forward. But you can see what their conclusions were, that in our search for a potent yet safe analgesic possessing a profile of qualities that are better, superior than existing agent, mitragynine looks like it's the real deal. It produces some pain effects, low respiratory depression, safe profile. It's not an opioid. Somehow FDA missed that when they said it's a deadly addictive narcotic like opioid. As a kind of an epilogue, how the world would have been different maybe in pain management if they had gone forward with it, but they didn't. By the way, that's their summary. Anybody that wants my slides, they're publicly available, and I'll send them to you. I tell you what, can you just click? I'll just say click because this is not reliable. As Congressman stated earlier, with FDA, we've got to work with FDA. So about 4 or 5 years ago, Mac Haddow said, what study would make a difference? I said, even though we know kratom doesn't cause respiratory depression like an opioid, we need to do FDA's test. Can you get the funding? And some of you folks in the room may have contributed the funding. I don't know who. I said, the deal is we're going to show the data to FDA and NIDA before you see it, and we're going to publish it no matter what the results are. We did that. And the curve with the blue is flat as a pancake. That's respiratory effects under a huge range of doses. And the green is the oxycodone control, and that produced the Death Valley effects on respiration and deaths in some of the animals. Next slide, please. This was a historic study that both Chris and Ed already mentioned. You know, science, a lot of it is just by accident and fortuitous events. So Dr. Boyer has somebody coming saying, hey, what's going on with this guy? And Dr. Boyer calls Chris McCurdy. So here he had lead kratom researcher and a lead toxicologist, an opioid guy that really knows pain and opioids. And looking at this, and look at their conclusion. We report self-treatment of chronic pain and opioid withdrawal with kratom. The predominant alkaloid kratom mitragynine binds immunokappa opioid receptors, but has additional receptor affinities that might augment its effectiveness. FDA got it wrong. It wasn't just a morphine opioid-like receptor. It's a diverse substance, and that probably accounts for a lot of the benefits. It's not a powerful analgesic. It does have analgesic effects, but it does a lot of other things that are important. Science, I love. Next slide, please. 2018, the FDA was stopped in its tracks by science. Now, that wouldn't have happened without advocacy and consumers, but it was science. After the FDA bombshell with the commissioner himself saying this is a deadly addictive narcotic like opioid, what did NIDA do? Ramped up its research. NIDA and DEA were actually closer aligned than FDA at that time. And we see Dr. McCurdy and others were already researching, but a lot more money came in. And I would say that is a success story in funding NIH and giving researchers that are creative and dedicated, like Dr. McCurdy and others, who then run with it and give us what we need for regulation. A lot we don't know, but anybody that says we don't know enough to start regulating doesn't know anything about regulation. There's plenty for FDA to start. Whether you're regulating water, food, drugs, you start with what you got and start regulating, and regulations evolve as you learn more. We got a lot of information. Scientist's letter to White House. We wondered, would anybody read that? And that made the case that if you ban kratom, people are going to die because people's lives depend on it in some cases. Secretary Joe Turner is chief of staff and says, FDA is probably right, but these seem to be credible scientists. Let's look at it. What did he do? After their investigation, they found the same things. They investigated independently. And actually later, Dr. Jor, in a tweet to Dr. Gottlieb, said, FDA's recommendation was rejected because of embarrassingly poor evidence and data and a failure to consider overall public health. If kratom's fueling the opioid epidemic, prove it. He knew it wasn't. Then in June, NIDA and College on Problems of Drug Dependence all agreed this is an important area in public health and science. In that single meeting, Dr. McCurdy had really a historic symposium in kratom because he brought together a lot of the lead researchers. 5 FDA people were there. I know because they were sitting right behind me. Dr. Smith gave and she was a baby at the time, 13 years old. She was giving one of the hot topics presentations, which are very well attended, on people with heroin addiction using kratom to stay off. NIDA brought in the Malaysian experts and had an international kratom panel. Here's the people who are saying, hey, kratom is an instrumental substance. And all of these sessions were attended by FDA, NIDA, and DEA. That was a very important point in stopping FDA's progress. Now I'm going to bring next slide, a little pain to the audience. You've heard a lot about pain. 2 weeks ago, I believe the first in history kratom presentation at the annual Pain Week convention occurred. And Dr. Raffa and myself co-chaired it. And when the audience was there, we had one of the larger audiences. I said, how many of you are treating patients with kratom or using kratom, your patients? More than a third of the hands went up. I said, why are you here? We want to learn more. They want information from FDA, they're not getting it. But why is kratom so helpful in pain? And again, there's no pain product. Kratom is not approved for pain or any other indication, so that's important to recognize. Next slide. However, pain, self-reported pain, is a major reason that people report for use. And what's really interesting is that people report that I got my life back. I made things better. What's going on, especially since it's not a powerful analgesic, but it does have analgesic effects that meet all of the tests in the drug company studies and others. Well, it has a lot of effects that go along with chronic pain. Next slide. And this is from a paper I presented at a psychedelic conference. We're learning that psychedelics like MDMA help a lot of people with chronic pain. What's going on there? They do not have analgesic effects. Well, chronic pain is a multimodal problem. It includes psychological components, and multimodal treatment works better. And the pioneers in a lot of this were the US military. In the 1990s, discovered that soldiers with blown off limbs did better if you gave them counseling, divorce counseling. What's that got to do with pain? Psychological counseling. But the people that got counseling, multimodal treatment, maybe antidepressants, they did better with pain, recovery, getting their lives back, and they needed less opioids and got off of opioids sooner. Well, as you already heard from Drs. Boyer, McCurdy, Smith, kratom isn't just an opioid. It has some opioid effects, but it has effects, emotional effects, mood-altering effects that are beneficial. And a lot of those are why people use it. And when I was first exploring kratom more than 10 years ago, I thought, what's going on? People are using it for fibromyalgia, post-traumatic stress. Well, fibro is, that's pain, sleep, and depression. It does all of that. Next slide, please. So the Lancet, and there's a revolution in pain treatment right now, and the revolution is a reset, that we have to treat chronic pain focusing more on the emotional and physical problems, helping people get their lives back, not giving up on relieving pain, but doing all of this. And kratom looks like in one plant, you get a lot of these effects, plus a bonus. And what's the bonus? What pain medicine actually increases alertness, mental acuity, and helps you get your job done better? Next slide, please. Okay, has anyone heard that we might have the first downturn in drug overdose deaths? A really hot topic. Nora Volkow weighed in on it in the last couple of days. Everybody's saying, what's going on? Well, is it real? Yes, but it's complicated. And guess what? It's not happening with stimulants and cocaine. They're flat or actually still going up a little bit. But opioid deaths are going down, and that was real. Will it continue? Nora Volkow is saying we need more harm reduction. We need more naloxone. She didn't mention kratom, but I think this makes it more important than ever. We know that there are some people whose lives dangle by the thread of kratom. We don't know how many. And kratom hasn't been mentioned in these discussions. But more than ever, we need FDA to step in and regulate and not demonize it. Don't scare people away what could be life-saving. And why is that so important? It's always important, but whenever there's an addiction going on, it's really important. You might have heard the old mantra in addiction treatment about denial. It's not a river in Africa. It's part of the addiction process. And people oftentimes love to hear that the treatment is bad so they can stay on what they're taking. We need honest, accurate information out there. And kratom, we think, is part of that solution. How big of a part? FDA, we have to get you at the table helping. And next slide, please. I showed this slide. Some of you might have seen it. I presented at an FDA hearing in 2018 on new treatments for opioid dependence, because that's when FDA was saying, well, it's not approved, so people should stop using it. And I presented this slide, and I heard later that NIDA colleagues liked it, and some of the people at FDA did not like it. I said, you don't take the life preserver away from somebody struggling in the ocean because it's not Coast Guard approved. Okay, last slide. Sustaining and accelerating, second last. The decline of overdose deaths. How many of you recognize that guy before you saw it? Mac Haddow worked for him. I was assigned to work from him in 1981 and basically until he died. He was a harm reduction guy. Dr. Koop understands that much of public health is harm reduction. Clean needles, less harmful substances. About nicotine, if you got to be hooked on nicotine, be hooked on a product that's less likely to kill you. This is very much what public health is about. But we need, and kratom also has the potential to help with alcohol and stimulant use disorders. That's part of NIDA's interest in it. But what do we need to do that might need more congressional support? Ensure that kratom remains accessible nationally. Kratom Consumer Protection Act. More states, and ideally we need it federally. Everybody should be protected, not just some people. FDA and others decry kratom for not going through FDA or having a new dietary ingredient notification. But FDA is denying all of those. And guess what? That process, if they do it, they learn a lot, because then for that product, they have to decide what are the standards, what are the relative ratios of substances that Dr. McCurdy told you are evolving, what is an acceptable kratom product. And then the industry knows what they can market, and they can make sure the legitimate players, we meet that profile, and if you don't meet that profile, you're not going to be on the market. Industry can't do that. You need FDA to do that. So there are a lot of things that we need Congress maybe to nudge, and I say encourage FDA, which you know better than any way, Representative, that letters, hearings, meetings. And recently, Representative Bergman and Correa, who had the bipartisan psychedelic caucus, issued a request for information to help FDA move forward more quickly on psychedelic medicines development. And they did that after the disastrous hearing with MDMA in June. I think that will get approved, but it's going to take longer, and they're helping move the process along. So last slide, conclusions and pleas, and I think most of this has been covered. But first, with support of research to NIH, this is an amazing success story. In just the last 10 years, the research publications have skyrocketed. I mean, when I watch Chris present, I mean, what we know now, remember 5 years ago he said, well, major constituent of kratom is 7-hydroxy. Well, now we know, no, it's a metabolite. It's actually in very low levels, and if it's high levels, it's probably been spiked, and we know a heck of a lot more. Although the overdose epidemic might be subsiding, we hope it'll continue. We need kratom in the game and legitimized, not demonized. Don't demonize what can be helping. NIDA has walked that path very carefully. It says kratom is not approved as safe and effective, but a lot of people are using it. Nowhere do they say don't use it. And DEA, that's part of the reason DEA opposed NIDA and walked away from trying to schedule it. Thank goodness for Dr. Jor for stepping in. Kratom's an underemployed health asset. How do we leverage it more? Balanced FDA oversight can protect and guide those for whom kratom is their lifeline, and provide standards for industry. Legitimate industry in just about anywhere wants to know what the rules are and what should the label be. FDA can do that better than anyone. Also, I would love to see what's happening in the psychedelic area from Congress, which is the Department of Defense and Veterans Administration have gotten in the game. And DOD in the last budget defense authorization bill said DOD shall start testing active duty people with post-traumatic stress with psychedelics. That will help move the ball forward. We need DOD and Veterans Administration at the table with kratom. There's more than 50,000 suicides per year in the United States, more than 15,000 of veterans and active duty alone, a lot of them related to depression and post-traumatic stress disorder that kratom helps some people with. So we need them at the table. Anyway, I really appreciate, I'm grateful for all of you here who are helping in this area. Really grateful for people in Congress that have stepped up to the table and are helping. And frankly, there's plenty of people at FDA that are ready to rock and roll in this area, but I think they do need some congressional encouragement. Thank you.
Thank you. Thank you, our panel of scientists, and we'd like to move quickly to the next panel, which is a group of kratom advocates. And In the interest of time, we only have this room until 11:30. Just like to ask the